Hello, everybody. Thank you for joining. We'll go ahead and get started. It looks like we've got people from all over the place: Atlanta, Georgia, Louisiana, Jamaica, Alaska, Italy. Well, Ornella, you win the award for the farthest distance. Tampa, Florida, New York. Awesome. Well, thank you all for joining. My name's Patrick O'Malley. I'm going to go ahead and get started. And welcome to today's webinar, which is entitled When Urgent Turns Emergent, Pediatric Resuscitation in Urgent Care. And this webinar is brought to you by EB Medicine. And EB Medicine helps urgent care clinicians get up to speed quickly and stay current on the latest evidence so that you can feel confident treating patients in the urgent care setting. Plus, they make earning CME credit very easy and affordable. My name is Patrick O'Malley. I'm an emergency physician in Newberry, South Carolina, and I'm the course director of the laceration course here at EB Medicine, and I'm going to be the moderator for today's event. After the presentation, you'll get to see a brief demonstration of EB Medicine's latest resource, which is made specifically by and for urgent care clinicians, and it's called evidence-based urgent care. If you stay until the very end, you're going to get a special bonus if you decide to subscribe. This presentation will be recorded and available to all registrants within 1 week. Now, on to today's session. I'd like to introduce you all to Dr. Merissa Rzonca. Dr. Rzonca graduated from SUNY Downstate Medical Center and trained at Cohen Children's Medical Center. She's worked in pediatric urgent care for over 12 years and is the Director of Emergency Preparedness Education and Director of Laboratory Services at PM Pediatric Care. The presentation is going to be about 40 minutes, and then we're going to have some time for a live question and answer session, followed again by that demonstration of evidence-based urgent care. This is really, really, really important material, and I hope you enjoy it. So take it away, Merissa.
All right. Hi, everyone. Thank you for joining today. So I will be introducing this concept of RESCUEepc, which you'll learn what that means soon enough. Just financial disclosures, as Dr. O'Malley said, I'm employed by PM Pediatric Care, and I'm a co-creator of the RESCUEepc course. PM Pediatric Urgent Care has over 70 offices across the U.S., and for that, I'm the Director of Emergency Preparedness. And in the last 2 to 3 years, my colleague and I, Dr. Nikhil Shah, have been working to develop this course. And it basically prepares urgent care providers and staff for managing emergencies in the urgent care setting. So today's just basically going to be a brief snippet of it. There's so much more to it and goes much deeper. But this is like a little sneak peek. But I'll at least be giving you some key concepts to be able to hold on to here. So for today, we're going to understand why the approach to emergencies in the urgent care environment is unique from what is currently available in regards to emergency preparedness. I'm going to introduce you to the RESCUEepc approach. We'll go through a few cases using the RESCUEepc approach. And from those, we're going to highlight some essential concepts and clinical pearls for managing pediatric emergencies that are frequently presented to the urgent care. So to start, pediatric office emergencies are not uncommon. It really depends on where you are and what the focus of your office is. A survey of 52 practices reported on average maybe one emergency per month, but other studies showed that you can have almost two to three events in peds and family practice offices in urban care settings, in urban settings for urgent cares. I've had nights where I've sent 3 kids to the hospital and then I've gone 2 months without sending anyone. So there's such a wide range of what can happen in these settings. Potentially life-threatening illnesses do occur in pediatrics and in urgent cares. The variety of what I've seen in my office, we've diagnosed leukemias, we've had splenic lacerations, grade 4 hepatic lacerations. You have your typical asthma and anaphylaxis. There's head injuries with neurologic compromise. We have seizures come in. We actually had a couple of gunshot wounds present to us. So there is quite the variety of what can come into an urgent care. Most common will be our respiratory and infectious emergencies, with seizures and dehydrations also being common. So providing urgent or emergent care until EMS can arrive for these cases is going to be necessary at times. So, stabilization of pediatric emergencies and early transfer for definitive care are critical. But how do we approach this in the urgent care environment? We all know getting the right care early, getting good, high quality care early can make all the difference. But the urgent care can be quite different from settings that many courses are geared towards, being either the pre hospital settings, such as ambulances and paramedics, or the hospital setting. So, questions we need to ask ourselves are, what kind of providers do you have in your clinic? Do you have a mix? Is it pediatric and adult care? Is it MDs and DOs? Is it APPs, your PAs and nurse practitioners? Is it people who have come from emergency care settings? Is it people who've come from primary care settings? How long have they been in the setting? It's quite a variety that you can get. So the experience that they'll have in managing critically ill children in the setting will also matter. You can have somebody who is the most advanced trained emergency medicine specialist come into an urgent care, and when you are used to the transition from being in the hospital setting where you have full teams, where you have every medicine, where you have every piece of equipment, you have trauma teams and all of this to back you up, and then transition over to an urgent care setting where you might not have a nurse or an x-ray tech. You might be the one administering and drawing up medicine, using equipment you're not used to using. It's knowing what the experience is of those providers who are on staff will make a difference in what your office can be prepared to manage as well. Also, your support staff, the clinical support staff, your nurses, your medical assistants, your x-ray techs, anybody else you might be having working in the office, it's important to know what their experience is and what their capabilities are. Can your support staff place IVs? Are they able to draw blood? Are they certified in BLS or PALS? Have they worked for years in an emergency care setting, or have they come out of a school nurse's office? The variety is plentiful as far as what you can find in an urgent care. That being said, to prepare your staff to be able to manage these emergencies, we've looked at what's available around us, and you have the various courses often offered by the AHA, National CPR Foundation, other all different resources for this, but you have your basic BLS classes, you have your advanced life support classes, your PALS and ACLS, APPLS, and you also have pairs. The other way you can work to prepare your staff is by using simulation, like mock codes, and how often do you do them? But what we found in our setting is that there were a lot of limitations to these. So you have, PALS, APPLS, and ACLS were primarily focused on in-hospital care. Adult courses don't tend to address unique aspects of pediatrics, but these more advanced courses also don't take into account what we don't have in the urgent care setting. We don't have wall oxygen. We have AEDs, but we don't have defibrillators where you adjust the voltage and everything. You don't have wall suction. There's again, limited staff, stuff like that. So these more advanced courses don't take that into account. BLS, everybody should have BLS. I feel like everybody should graduate high school having BLS at a basic, but that's my opinion. That being said, though, that covers CPR, but for all the different types of emergencies that come into play in an urgent care, it definitely does not cover everything. Pairs is an interesting option as well. It does cover some pediatric emergency situations, covering shock and respiratory illnesses, but it does not encompass all of what's available in many urgent cares as far as the medications we can offer, and just the variety of care and equipment we're able to do, if not treat that patient to the point of being able to go home, but even to the point of being successfully transported with the best possible outcome. So this doesn't cover all that's possible to use in an urgent care. Simulations are good for practice, getting everybody familiar with what's in your office, but also doesn't always dive deep enough into understanding the fundamentals that are explained in BLS and PALS and pairs. So we kind of really do need a combination of both. So the bottom line is attempting to use this knowledge and skills acquired in these courses to manage patients in our setting, the urgent care setting, often feels disconnected, poorly relevant, not reflective of what's in our offices. So what did we do? We introduced a novel course that is relevant to our setting, higher yield, and shorter and less time intensive. And that is our Rescue EPC course brought to you by the PM Pediatric Collective. What is Rescue EPC? It is the Resuscitation and Stabilization of Children in the Urgent Care Environment Emergency Preparedness course. What are the rescues of EPC, of Rescue EPC? It's far more relevant to the outpatient setting. It's much more practical, less tangential than what we found in some of the more advanced courses, so allowing it to be more simplified. It's easy and efficient for adult medicine practitioners to complete. All course content is reinforced through some simulation scenarios that we've developed. It's a one-day course. You're able to do half. It's actually even just half day, often even under 4 hours in person with about 4 hours at home. So it's less expensive, less time commitment, just easier to use. So what have we found? So we have opened this course to in-house as far as being able to roll it out and see how it works in real life, as opposed to just being theoretical on this. And based on some pre and post course surveys, what we found overall is that with the blue bars, you can see that pre-course, how prepared students felt for managing emergency scenarios was certainly better after taking rescue. And the first bar just talks about hospital setting, but then we break it down into the different types of emergencies that can come in. And across all types of emergencies, we see improvement in their preparedness, up to even 40%, around 40% better than, depending on the scenario. Cardiac arrhythmias has the biggest improvement. Respiratory scenarios that are probably the most common that we see, obviously less wide of a gap there. But the other interesting thing here is these questions over here were pre-course, before they took rescue, how prepared they felt for emergencies based on what they were taught in PALS and taught in BLS. But then after, the jump for how well they felt prepared for emergencies in the urgent care settings after getting rescue, just based on, because so much of it is based on what's very specifically available in urgent cares. And you see this is a really nice jump, about 40, almost 47% better compared to the other course options out there. The other nice feedback that we got here was that when we asked them, compared to PALS, how well did rescue prepare you for emergencies in the urgent care setting? None of them felt that it was less prepared. 100% felt that it was the same or equal to, but almost 80% saying that rescue prepared them more well than PALS was able to prepare them. So again, we seem to have targeted what urgent cares need through this program. Typically, when we teach rescue, again, it's a blended learning format that can take about a day to do, with 4 hours of online homework that you can do on your own time, virtual modules, etc. And then the instructor-led classroom training that includes skills assessments and practice scenarios, as you can see down here. And there is written tests and a mega code that we do. However, today, I have 30 minutes to go through all that. So we're basically taking hundreds and hundreds of slides and boiling it down to about 30, I think. So what we're going to do today is I'm just going to give you some of the real highlights of rescue. We'll go through some quintessential cases, and from those draw out some pediatric pearls that can be useful in your setting. To start with, we have the I-4 rescue cycle. The I-4 rescue cycle is basically the approach we're going to take to any emergency that comes through your office. And you'll start with identifying that there is a patient that's critically ill, interacting with the staff to mobilize your resources, intervening for what you have in the urgent care setting, and initiating early transfer. And all of this, of course, will cycle through based on reassessment and how the case evolves. So a patient will come in, you're going to identify, you'll interact, intervene, and initiate early transfer. This is your I-4. That's like the bird's eye view of this. To be a little bit more specific going through this, we have the rescue protocol, and you have your initial impression that you gain by using the pediatric assessment triangle. We'll go through that. Mobilizing your resources by alerting your provider and team, obtaining equipment, your critical interventions, which will be your ABCs and secondary assessment. And then once you've figured out what's specifically going on with your patient, you can have your more directed interventions. And you can see how this lines up with that I-4 cycle, with your identifying, interacting, you're intervening both critical and directed, as well as remembering that at any point you can be initiating early transfer once you realize that the patient is acute enough to require this. So first, your initial impression. Initial impression is you walk into a room, you haven't even laid laid hands on the patient, but you are now laying eyes on the patient, and this is what you are seeing. It does not involve getting your stethoscope out, does not involve palpating anything, nothing like that. This is you walk into the room and this is what you see. And this is based on the appearance of the patient, the work of breathing, and their circulation can also be briefly assessed. We'll get deeper into that as you go on in evaluating your patient, but this is first glance. Do I think this patient is sick, and how sick do I think they are based on this triangle? And you can see that the more sides of the triangle that are affected, it can be an indicator of how severe the patient actually is. So again, you can have a patient who's just, maybe looking sleepy, lethargic, but, in the case of a respiratory patient where, okay, you see a little bit see a little bit of increased work of breathing, and the patient also looks cyanotic, you can see how this is a progression of how severe this patient might be. Same thing for somebody in shock, where you might see they look a little bit pale, but when you see somebody looking a little bit pale and lethargic and, change of responsiveness, the more sides of the triangle you have affected, obviously the patient is looking worse. And when you have all three sides of the triangle affected, this is somebody who could be at risk. Doesn't mean they are in, excuse me. It does not mean they are in cardiopulmonary failure, but that they are at risk for impending cardiopulmonary failure. Excuse me one sec. Okay. So continuing through that rescue protocol, after you get that initial impression, you'll need to mobilize your resources. With mobilizing resources, this is getting your team together, alerting the provider that something's going on, getting your staff into action to obtain equipment and get everything where it needs to be. I'm not going into every detail on this very busy slide. The main thing I'd like you to take away from this is that in an urgent care, you can have these full team or small team models where in the full team, you might have multiple providers on, you have a nurse, you have an x-ray tech, you have an MA, you have everyone. But sometimes you can be quite skeletal, where it's like you, the front desk person, and someone from the clinical support staff. Could be a nurse, often not a nurse, could be an MA, maybe not, could be an x-ray tech. So it could be quite a variety, and you can see how pivoting from the full team to the small team role, there's a lot of overlap in what the responsibilities and roles of each member of the team might be. And it's also important for those team members and for you to know what the roles is of each team member to help minimize errors and anxiety, just like knowing what you can expect of each other. The other thing to notice is based on everybody's roles when you're mobilizing personnel. I feel like when we learn a lot of or go through a lot of these courses and teachings, it's very sequential. But what is actually happening in real life is you have every member of your team, everybody's acting at once. All of this is happening at the same time. So it's kind of in concert. And in doing so, you're winding up with efficient management of a critically ill child. You want to make sure you mobilize your equipment. I'll go through this quickly. And this can vary based on what you have in your office, but it could include your vitals cart, could include, the vitals cart, the glucometer, an IV pole, blood pressure items, pulse ox. You might have a code cart. Some people have a code bag, but your critical emergency items, you should know where they are and what they include. In our offices, we have AEDs, portable suction devices. We have a critical care guide as a useful resource for our staff. We have an anaphylaxis kit, we have an EKG machine, etc. And then what you have in the way of oxygen supplies, which will typically include your oxygen tank, your oxygen delivery methods beyond the tank as far as your tubing, BVMs, mask, cannula, etc., possibly a nebulizer. And then once you've got your people and your equipment and your mobilized, you will start intervening. First will be your critical interventions. These will include your ABCs, your airway, your breathing, and your circulation, and what you'll need for those items. As part of that, once you have started intervening with those critical measures, your ABCs, as you're doing that, you'll be obtaining your secondary assessment, which can include your sample history, where you're asking for the signs and symptoms the patient was showing. You're asking about a history of allergies, any medications they might be on, and their past medical history, as well as what their last meal might have been and the events leading up to what brought them in. The it's basically you've pivoted from, okay, and I've seen and viewed that the patient is in distress. Now I'm taking action, we mobilize everything, and I'm intervening with what they will most immediately need as far as their ABCs and finding out more so I can figure out what their directed intervention will be. So those first three steps that I just reviewed, any critically ill child, you're going to do these same steps for all of them, regardless of what's going on for them. However, the directed interventions, now that you've been able to tease out what's going on, it's respiratory, this kid has asthma, or it's respiratory and this kid's having an anaphylactic reaction. You've teased that out based on what you've gleaned from your ABCs and your sample history, et cetera. And now you can figure out what they more specifically need to help improve um, their symptoms. We break this down in the course to cover respiratory emergencies, shock emergencies, cardiac emergencies, and the unresponsive or seizure patient. I'm going to show you some stuff that looks real busy. We are not going to dive down that deep into it because I'd really like to be able to spend more time going over these cases with you. But it's just to give you an idea of how much is actually possible in the urgent care setting based on what you have and to see how we're able to break this down. So again, I know this is a very busy slide. I don't want you to feel like you need to read all of this, and I'm not going to read all of it to you, but just again, seeing how you have this common pathway here that all of your critical patients will have, and then based on symptoms, being able to tease out what more specifically is going on based on your signs and symptoms, and then for what can be available in the urgent care setting, what steps you can take for them. In the actual course, you'd be able to even blow it out even more and see this a little bit more step by step. So again, this would be for a shock patient, but then next up we would have, we cover shock, we cover respiratory. This is also the example for cardiac. Again, I'm not going through all of these minor steps, just a couple of points I want to make here. If you have an unresponsive patient, you kind of forego all of this and you go to your unresponsive pathway for a patient and what you would need to do for them, and kind of work back from there once you've addressed those more critical needs. The other item here, again, if you have an EKG in the office, based on what's going on in urgent care compared to hospital setting, you are likely not going to have all the medicines they may use. You will likely only have an AED, not a defibrillator where you can synchronize your settings and or do synchronized cardioversion, adjust the joules, all that type of stuff. You're really just working with an AED. So based on this, it will be more important for unstable cardiac patients to have an AED attached rather than lose time trying to obtain an EKG because you're just delaying that more definitive care. More important to get the AED attached and call for transfer. So on some of these, you'll see in these unstable patients is that you won't perform an EKG until after your ABCs have been established and you've initiated transfer. Again, I know this is a lot of information, and I know I'm not covering it all, but for purposes of time, it will be better to move on. So we saw the unresponsive patient as far as how that breaks down. And then the last of the I-4 cycle is that initiating early transfer. And even though it comes in last, we should always just keep in mind that this can be considered at any time. We get better outcomes with early transfer. You want to activate transfer early for anybody, especially for those showing signs of impending cardiorespiratory failure. You can reassess some patients. Great. You might think you can handle them in office, but you want to reassess. Are they improving? Are they showing improved effort? Have vitals improved? And then a really key thing in urgent care is making sure that even though you can do it, you've handled this in ERs before, you've handled this in your own office before, you're very comfortable with it. but based on what you have available to you in that moment, okay? And this can change from shift to shift, day to day, season to season. Um, First, what is the likelihood that you can fix this patient and send them home? Because if you're going to spend 3 hours working on this kid, giving med after med, doing all the steps, but you're still going to send them to the ER, why? I don't want to say why waste your time. You're not wasting your time, but why divert all of that care when you might be the only provider on? You might have 40 other patients waiting. You might have it's a lot to focus on one patient when they're going to go to the hospital anyway. So it would be better to just transfer them sooner, let them get to advanced care where they're stretched a little less thin, likely, and where they're going to wind up being anyway. So we just need to ask yourself, just because you can manage this patient doesn't mean you should. So many things to take into account with that, patient volume, the experience level of the staff you have on, the amount of staff you have on, several other things as well. And honestly, if there's any doubt, just send the patient out. So we're going to go over a few cases. So just as a quick, so you have the visual again, the I-4 rescue cycle. We're going to identify these patients, what's going on with these. We're going to identify that these patients are in distress. We're going to interact with our staff. We're going to intervene with your critical and directed interventions, and you're going to initiate transfer. We're going to take this, and this is basically a learning tool that we use in the RESCUEepc course when we're in the in-person session, going through practice scenarios. We basically kind of unroll this cycle a little bit and use a format like this to kind of ingrain this habit of this pattern of thinking through these scenarios so that it becomes much more of a knee-jerk reaction rather than a scattered, what do I do first approach, right? So again, you'll be identifying what's going on. I'm going to try to do this as best as possible in this format. It works obviously a little bit better in person. I'll try to watch the chat here so I can see what people are responding to this before revealing what's actually going on. We'll kind of take it step by step and work through the initial impression, the interactions, getting your ABCs and sample history, and then seeing what teases out as far as needs for transfer. Okay, but this way you know how this is supposed to look. Okay, so in our first case, we have a 6-year-old male with difficulty breathing for the last 6 hours in the setting of upper respiratory infection symptoms. He's got a cold for the last 2 days, but so 2 days of a cold, but now in the last 6 hours, really working to breathe. Okay, so we have this layout that I gave you, and I'll reveal bit by bit. The patient has come to the office, and you walk into the room, and you see that the patient is awake, alert, quiet, but anxious appearing. He's breathing fast, pulling, retracting. You see some nasal flaring, but he's not cyanotic and doesn't have pallor. So in that first initial impression, your knee-jerk reaction is, is the patient in shock? Are they unresponsive? No. But this patient is in respiratory distress. I think that's pretty easy to see. How severe is it? Well, you've got two sides of your triangle affected. So I would, as far as what you want to activate and how quick you want to be acting for somebody with two sides of the triangle being affected, until proven otherwise, this is a little bit more severe, right? So now that you've identified, you start interacting, you get your staff in action, and they collect the vitals. You see that the patient is breathing 38, not too fast, O2 sat 96, certainly not terrible. But again, based on that initial impression, you still want to mobilize things as far as, have your oxygen at the ready, get a nebulizer for a patient in respiratory distress, as far as what they might need. Know where your meds are for what this patient might require. And then at this point, you'll continue to intervene, but you've got to get that primary assessment. So you'll be examining the patient. This patient has a patent airway, has an increased respiratory rate with suprasternal and subcostal retractions, nasal flaring, poor air entry. They're tight with expiratory wheezes all over, diffusely. Brisk cap refill, warm skin, is alert with no deficits and no exposures at this point. So again, for this patient, O2 is at 96, but working to breathe. Could you give oxygen? I mean, I wouldn't say it's required that I be demanding it, but could you consider it for somebody who's working like this? You could. But wheezing all over, Could be reactive airway, could be known asthmatic. We don't know that yet. But I would probably want to get my nebulizer out and ready. Again, so you can see the critical interventions for this patient. This is likely lower airway obstruction due to asthma or reactive airway. And again, oxygen might not be necessary, but you do want to have that nebulizer ready with an appropriate way of delivering it, whether a mouthpiece or mask. And then working towards your secondary assessment, find out a little more about the patient. This patient has increased work of breathing for 6 hours, mild cold symptoms, no fever, has no known allergies, takes albuterol. The last dose was an hour ago, had no improvement with it, and also had 3 other doses in the last 6 hours. So this kid's gotten a ton of albuterol and is still breathing like this. Has a history of wheezing with cold, had lunch 4 hours ago, and again, woke up with difficulty breathing today after 2 days of cold. So my directed interventions for this patient, what might you do for this patient? You want to give albuterol. In this case, we would try to go for a COM-EVENT if you have that available to you, the albuterol with ipratropium as opposed to just the plain albuterol. He's obviously been getting albuterol all day, and the albuterol by itself is not making much of a dent. So you would opt towards the DuoNeb or COM-EVENT at this point. And these would be administered by a nebulizer. You could repeat this a couple of times, but then after that, you would do just the albuterol. And you would also, for this patient, administer high-dose dexamethasone, that one-time dose. You would want to reassess after each dose and see what you would need to, what your next best course of action would be. This patient does improve a little bit, but you also notice that the O2 sat dips a little bit here. You see that the O2 dips a little bit here, and we'll discuss that when we talk about the clinical pearls. But the patient has improved air entry, and the wheezing seems increased. So in pediatrics, some of the stuff that we can see, and I'm sure this occurs in the adult world as well, even though you have improved air entry going down to the base, you can actually hear the air moving. They could have been so tight to begin with that it was actually muffling some of the wheezing because air couldn't pass through enough to create the sound of wheezing. Now that they're opening up, air is actually getting in, which is great news, but it makes for more sound as far as the hearing all the wheezing. The dip in oxygen saturation, I'll talk about VQ mismatch in a moment, but it's not unexpected in a patient like these. And I'm seeing that Dr. O'Malley is saying how with the number of nebs that this child had already, you would consider early transfer. Could you turn them around in an hour or two? I would want to, it would depend on several things for me. First of all, what time is it? Is it a half an hour before closing, or is it the first hour of my 12-hour shift? Could I potentially turn this around once he gets steroids and gets a couple of comments? I've definitely seen that turnaround. But am I going to do this to my staff that's already been on for 11 and a half hours and turn it into a 14-hour day for them? Probably not. So a few things go into making that decision. In this case, with a kid who's not oxygenating poorly as far as an O2 sat of 96%. So it's a little bit of a judgment call. It does not need to be a knee-jerk reaction. You'll take a few things into account. And then, yes, so closing time, yes. And I see Karen Sadow's response as well. Again, it's a maybe. I'll go through some pearls first and then address more questions later. For this patient, early transfer, what we've just went over, is the patient hypoxic? Are they O2 requiring? Is that O2 sat under 92%? To me, 96% with a patient who is responding well, I'm not too uncomfortable with that. Under 92%, I'll hesitate quite a bit more to send them home and probably veer more towards transferring to the ER. If they're having poor response to these directed interventions, I gave 2 DuoNebs, they're still retracting all over the place, oxygen's still hovering at 92, something like that, bye. And then significantly decreasing heart rate with signs of fatigue. You want to watch for these kids who are just heading towards failure. You might see that respiratory rate come down. Parents are like, oh, good, they're so much more settled. They look comfortable. To me, my red flags go up. I want to know that the heart rate is up, the breathing is good, the oxygen saturation is good. This is a patient calming down like this, getting sleepy, where a parent might think, oh, great, they're comfortable enough to sleep. To me, I need to see all the vitals first before I'm on board with that. So some pearls here for your pediatric patient with asthma or reactive airway. beware the happy wheezer. You can have a kid just playing and happy and bouncing off the walls, and they're just wheezing like crazy. And then um, again, all of a sudden they're sleepy. I'd be watchful of them, especially with a prolonged history like this child had over 6 hours getting that many nebs. BQ mismatch that I had mentioned. This is the recruitment of those bronchioles and alveoli that had clamped down so badly from the wheezing. Now, as it's opening up, you're getting better oxygenation of the airways, but the blood flow had diverted around those clamped down alveoli. As that airway opens back up, the blood flow needs to open back up. You get that little bit of a mismatch. So usually if you see that little dip in oxygenation, I watch that. I won't say it's not a problem at all, but it's something I watch, where if overall everything else is looking better and just the O2 went down a little bit, give it 15, 20 minutes. I will check the O2 stat again. Typically it rises back up in that amount. Drops in heart rate, respirations, O2 sat with decreased activity can be that ominous sign for impending failure that I was talking about. As far as some kids, especially those little ones under the age of 2, especially if they've never wheezed before, the nebulizers can be noisy and scary for them. They don't understand what's happening. There's steam coming up their face. You're putting this mask to cover them. They're being helped. It can be a little bit scary for them. Have the parents assist you as much as possible. I've had to have 3 people hold down a 2-year-old to get their nebulizer. But I also find it interesting to see how, especially when they are a little bit hypoxic, when they're not getting enough oxygen, you're not always entirely reasonable either. And as they get that treatment, see that they're improving, they're breathing more comfortably, they're suddenly much more calm and reasonable about what's going on around them. There was a mention before, I saw a question before about using a nebulized bronchodilator versus a spacer. There are studies that have shown that the inhaler with spacer is as effective as the nebulized albuterol. In general, if you're needing a combi or a duoneb with the ipratropium as well, you're going to be using the nebulizer anyway. For a more mild patient, where I'm only doing albuterol, for me, whether I'm using just albuterol versus albuterol with combi depends on how severe they are when they come in, what else they already got at home, and is this a kid who's their pre-existent asthma as well, as far as which way they tend to go. A patient who's a first-time wheezer and I'm just hearing, a mild expiratory wheeze, yeah, I'll just use albuterol for them. I don't need to go overboard. But a child like this one, I'm going to use the combi. If they use an inhaler with spacer at home and they already have that at home, in my office, I'm not going to make them pay for a spacer again, since those are single patient use. So then I'll probably use a nebulized medicine there. If they've never wheezed before, this is their first time wheezing, and I think they're just going to respond to albuterol, I'll actually do the inhaler with spacer that we provide in our offices. And if they get a nice response with that, then great. That's one less stop to the pharmacy for them because they're taking that inhaler and spacer with them. And to me, the benefits, especially of a poorly cooperative toddler, having the mask on their face for the 5-10 minutes a nebulizer could take to run versus the few breaths of the spacer mask, and the portability of the inhaler with spacer. There's a lot of benefits to it for the families also. Sometimes it's also just a discussion with the parents to see what will work best for them. Dexamethasone over prednisolone. It is now the standard of care for reactive airway or asthma exacerbations to be using dexamethasone over prednisolone. It's typically a one-time dose in the office, makes for great compliance, works very well, stays in the body for up to 3 days, and usually gets them over that hump. For more severe cases, though, you can consider sending them a second dose to be taken a day or 2 later, or if they also have a history of being a little bit more prolonged, but still better compliance and better outcomes than doing just the prednisolone. As far as your determination of transfer, the severity tolerated is going to depend on the staffing census. I had alluded to this before. So this is that covers this case. not sure if you'll want me to address any questions for this one now or move on so we can cover more cases and I can circle back for questions later. Okay, so I'll start with the next case. So we have case 2, 12-year-old female with sudden onset of rash and labored and noisy breathing. Again, we'll work through this. I know we're cutting short on time. This patient, she's awake, alert, she's anxious with rash all over. You're seeing her work to breathe and she's looking a little pale. So right there, that's 3 sides of the triangle. My flags are up to make sure I act pretty quickly with this patient. This patient's in respiratory distress. As far as you can see for now, we'll go a little further. She's got, so what's really important, what I want to tease out in this one is when you're working through these cases and thinking about it, you'll see here, it says if requested. As far as the blood pressure, when we're doing these practice scenarios, right over here, if requested, when we're doing these practice scenarios, a lot of times when we're working through these simulations, a lot of people forget to ask for the blood pressure or obtain a blood pressure. And in any patient where you're worried about shock, anaphylaxis, poorly responsiveness, you got to get that blood pressure. So we kind of make a point going through these practice scenarios to not verbalize that and kind of make the provider ask to make sure they remember to ask for that blood pressure. So in this patient, we ask for the blood pressure, it was good blood pressure. When we go through these scenarios, if they don't ask, we usually give them a worse blood pressure so that it kind of unfolds so that the patient is more severe because you didn't address their blood pressure. So you mobilize your staff. If you have an anaphylaxis kit, great. Otherwise, code card or your emergency kit, you want to, this patient, you'd want to get, even though stat here is 96, again, knowing that there's respiratory distress involved, you want to have that O2 tank at the ready. Possibly a nebulizer. She has stridor at rest. She's tachypnic with retractions, brisk cap refill. Even though tachypnic with retractions and stridor, there's no wheezing heard. Brisk cap refill, no focal deficits, but she's anxious and she's got hives all over. In this patient, sounds like upper airway obstruction due to anaphylaxis. You'll want the appropriate oxygen delivery method just in case, but you'll be considering a nebulizer to help deal with that stridor. Any patient with anaphylaxis, you can certainly consider vascular access, but key to note, again, with anaphylaxis, this should not delay epi administration. The secondary assessment on this patient, just to cover the bases quickly, she's got an itchy throat, itchy rash, and difficulty breathing. She has a known allergy to peanuts. She has an EpiPen, was afraid to take it at home, so came in holding the EpiPen in hand, which often occurs in our offices, and it was not yet given. History of asthma as well. Takes albuterol. At this point, was not administered. It came straight here from a party that they were at where she had lunch and dessert and ate a cookie and immediately began itching, not realizing that there were peanuts in it. And this patient will give epi. She is 52 kilos. She's 12 years old. So this would be your 0.3 milligrams IM. You can consider giving racemic epi to help with the upper airway. The IM epi might help with this, but working from both angles for you to maintain an airway is not an incorrect thing to do. Adjunctive medicines that you can consider include an oral antihistamine and dexamethasone. There's plenty of studies saying that dexamethasone might not be needed. Many providers still want to give it. As far as an oral antihistamine, traditionally we've used Benadryl. More recently, more and more studies are showing that tyrosine is the better choice, lasts longer, less side effects, and works with similar onset of action. But that being said, even though you want to give these, none of these should happen before giving that epi. Epi needs to be the priority. You reassess this patient. She's improved. She's more comfortable. Stridor retractions and throat itching have resolved. Hives are improving. You can monitor this patient. In your urgent care setting, this can depend on protocol for your offices. In our offices, again, this patient, if they come in at 2 p.m, I'm happy to observe for newer studies are saying you could observe as little as 1 hour. Traditionally, 3 to 5 have been a guideline, but also depending on the response. With a swift positive response to the epi, it could be as little as 1 hour. For a response, you're having to give more than one, guess what? They're going to the ER. If they're hypoxic, if they're hypotensive, if there are multiple symptoms, poor, slow, sluggish response to the epi, very easy to have a low threshold for transferring to the ER for this. It would be IM. Somebody's asking about IM or sub-Q. We give IM in our offices. So pearls for anaphylaxis, pediatrics, always make sure to get that blood pressure. Epi is a priority. Don't delay it for anything else. You have a patient where you come to the conclusion it's anaphylaxis, the first thing you're going for is epi. Epi dosing is really quite simple. If they're less than 30 kilos, you have your 0.15, over 30 kilos, 0.3. If you have a patient who's especially larger, considerably over 50 kilos, you can also do 0.5. There are some guidelines out there using 25 kilos as a cutoff, but with researching with the allergy, the AAAI, looking at what they recommend, we are still sticking with a 30 kilo cutoff. Having this quick pull up as opposed to calculating per kilo dosing, we really try to just use the standardized dosing rather than open ourselves up to errors with math and the time that it takes to do that, rather than just being able to do the knee jerk, just like EpiPens are the 0.15 or the 0.3. This is not an incorrect thing to do. You want to warn patients and parents as well of epinephrine side effects. Sometimes kids can wind up being uncomfortable from it. They get that flush. They get the flush and rush, so to speak. They get jittery. They feel their heart race a little bit. Sometimes they throw up from it. Warning them that this can happen is not them actually worsening. It's just that rush of the medicine. I would warn them of that. Your ABCs are still first. So you're still getting oxygen. You're still making sure the airway is open, but no directed intervention should supersede the epinephrine, as I stated before. And I also went over how cetirizine is now the standard over diphenhydramine. Any hypotension deserves transfer. That I would not have sit in my urgent care. Case 3. 3-year-old male with vomiting and diarrhea for 3 days, increasingly obtunded over the past 2 hours. So in this patient, he's lethargic. He's got no respiratory distress, but he's pale and mottled. So now again, you have two sides of this triangle. My radar is up for this patient who's in shock. Vitals, 3-year-old. So a key point here, and again, we go over this deeper in the actual course, is blood pressure of 72/45 for a 3-year-old male. You want your systolic to be twice for patients who are 1 to 10 years old. You want that systolic to be twice their age, 70 plus twice their age. And he's only at 72 here. He should be at least 76. So this is a hypotensive kid. His heart rate is up. That's your first key that there's some shock going on here. And then the blood pressure being hypotensive, this is your hypotensive shock. You're going to mobilize your staff. This patient's poorly reactive. As you go to assess him some more, you see he's responding only to pain. Again, here, D-stick if asked. So if this was a scenario in teaching the actual rescue course, we kind of withhold this and wait for the provider to ask this. But again, anybody with an altered mental status, poor PO intake, seizure activity, anything like this, you'd be asking for a D-stick. But again, A, B, C, D, E, right? His airway is patent, his lungs are clear, his cap refill is a little bit long there at 3 to 4 seconds. Only responding to pain. And again, if you ask for the D-stick, he is a little hypoglycemic here at 38. So this is a patient in hypotensive, hypovolemic shock. He's been vomiting and not eating for the last few days. And now he's also hypoglycemic. So you want to get vascular access on this patient. You want to find out a little more history. He's had 3 days of the vomiting and diarrhea, as we know, with poor PO intake and just very sleepy today. He hasn't been able to eat anything. He's maybe getting sips of water in and that poor responsiveness. For this patient, we all know to do that normal saline bolus, the 20 cc's per kg. Somebody who's poorly responsive like this, you would even consider doing the push-pull method of delivering that medication, use that bolus, I'm sorry, not medication, bolus, using a 3-way stopcock. But you also now know that this patient is hypoglycemic, so you can do a dextrose bolus. What we keep in our offices is D10. You'll want to know what you keep in your office and how it might need to be diluted if it's more concentrated, like if you're using D50. But you'll want to give that as a push as well. And again, a later consideration would be giving the undensitron, but your priority here is going to be the fluid bolus and the D10 push, or the dextrose push. With those, he does improve. But for this patient who's not able to tolerate fluids, was hypotensive, this patient is going to the ER and being transferred sooner rather than later, even though you can get the ball rolling on all of those. Well, I've got 2 more cases if I can power through them for you. So the hypovolemic shock, again, always get a blood pressure and a D-stick if you have a lethargic patient, poorly responsive. Decreased blood pressure in pediatrics is ominous and late sign for impending failure in children. children, it's like the last thing to go. So if blood pressure is going down, they are at that cliff. So you want to respond to that pretty quickly. Obtaining a blood pressure can be challenging in children. If they're lethargic, probably not, but in a kid who might be a little more alert and reactive, you want to make sure you're using the correct cuff size. You might even consider getting a manual instead of using the machines that just tend to like squeeze for 20 minutes before it ever actually gets the blood pressure, and then the kid's all agitated. So those are things to consider for them. If this is a patient who might be diabetic, as far as being lethargic and vomiting, consider having them use their own glucometer or use their lancet. Typically, the office lancets that we have has giant needles and they're really kind of mean and painful. So if they have their own lancet, it's fine to let them use their lancet, even if you want to use the glucometer your office has. It would be prudent for your office to have a list of normal values by age for all the vitals, so you're not sitting there trying to do the math of what's normal for this child or not. And it's also good for the support staff to have, so that it can be an indicator to them that even if they thought the patient looked okay, all of a sudden the vital looks wonky, they can come to you and alert you of this. Often when we have kids come to the office vomiting, ondansetron with oral rehydration therapy can be sufficient for most pediatric gastroenteritis. But if you have a patient with hypotension, this should not be your go-to. You want to respond to that with fluid boluses. For hypotension or altered mental status, again, use that push-pull method that I had mentioned. So, okay, I'm gonna keep pushing forward, I'm sorry. Hypotension deserves transfer. I went over that as well. Case 4, we have a 7-month-old male with poor feeding, difficulty breathing, and decreased wet diapers since early this morning. This can be a little disconcerting to many because this is pretty vague as far as what can be going on for him. But when you look at this patient, he's sleepy, he's grunting, and he's pale. So now you have all 3 sides of the triangle affected here. So this is a patient where your red flag should be going up. Is he shocky? Probably. The blood pressure, so you get the vitals on him. The pulse is you have your temp 37, pulse is 250, respiratory is 44, O2 sats 93, blood pressure is 62/44, and he's an 8-kilo baby. This pulse of 250, it's well over the 220 for infants. That would be your cutoff for acceptable range of tachycardia. And then you have this lowish O2 sat. He's hovering at that cusp there. So you definitely want to mobilize your staff to be able to figure out what else is going on here. If you go to examine him, his airway is patent. He's got bibasilar crackles, so that should be concerning you right off the bat. He's got a prolonged cap refill of 3 to 4 seconds. He looks pale and mottled. The pulses are weak. But he is responding to voice. So in this patient, with that heart rate over 220, that should be a quick trigger reaction there to considering a patient with SVT. But this patient with prolonged cap refill, decreased oxygen saturation, and bibasilar crackles, you should be concerned for cardiogenic shock, which makes this patient unstable. As you're mobilizing everything, getting the equipment you might need, you could be asking, what's been going on? He's had decreased feeds, as we've said in the history, decreased urinary output, and difficulty breathing, but otherwise, relatively clear history. He was an X36 weeker, maybe took 2 hours over 4 hours ago, but the difficulty that brought the parents in really came more in the last 2 hours. So for this patient that you're thinking SVT, he's unstable, so you may or may not get an EKG, but for a patient where you're highly suspicious for SVT, you could consider getting that EKG. And in this patient, it looks like this, and it confirms your SVT. And you can be doing vagal maneuvers while preparing adenosine. Vagal maneuvers may or may not work. If they work, great. If they don't, you need to have that adenosine ready. And that should be given with a rapid IV push. And you could also do, again, he's in shock, so you can do a normal saline bolus, but you have to remember that this is cardiogenic, so you need to go at 10 cc's per kg, and you want to make sure you're giving it low and slow, okay? The patient does improve after doing some vagal maneuvers, but will you still transfer this patient? Absolutely. The patient was hypotensive, they were in cardiogenic shock, and SVT has a tendency to revert, so that does require a transfer. Your pediatric pearls here, vagal maneuvers for them. Infants, you can do knees to chest, kind of like what you might do for TED spells. For a patient who's old enough, having them blow into a syringe, I'm a big fan of this method. Many used to say a straw. I find the syringe to be more effective. With the syringe, um, funny aside, I also found that it works for hiccups. So if you have a 10 cc syringe or a 20 cc syringe, go for it. But the 10 cc syringe for 15 seconds with them leaning back a bit, with their legs raised, shortly after, you can see the heart rate come down nicely. Ice to face is a classic. You do not want to be gentle about this. You want to be sudden and fast. You want to cover their face, but leave their airway open so that they can still breathe. Okay. Um, IV access should be in the antecubital location so that it can be more accommodating to that rapid push for the adenosine. And again, the rapid push, you'll push using that three-way stopcock, you'll push the adenosine. But the rapid push, because the adenosine is small enough dose that it might only fill the tubing, the rapid push is really the saline after. And you want to maintain the EKG during the interventions. Unfortunately, I do not have time for the last case. I apologize. There was a lot to fill in here, but I am definitely more open to questions. But just a note with SVT, transfer due to their tendency to revert, even if you are successful in the office. I apologize for kind of cramming it all in there.
Awesome. Well, this is a lot of information, and I think that this is something that it's pretty obvious that we could spend 3 or 4 hours here. And I think, just to reiterate that this is an introduction. This is not a, comprehensive overview of everything that we need to know of taking care of sick kids, just because it is such a broad topic. And we do have a couple of questions here. If you can, Dr. Rzonca, if you want to take a look at them, but I'll just kind of throw one out here. Let's see here. Reviewing normal blood glucose levels. What's normal in each age group? Is there a quick, easy way to be able to keep track of that?
So in newborns, they have a slightly lower threshold, where you'll want them to be over 60, but in general and pediatrics, if it's under 70, with symptoms like this, that would call for your D10 push,
Okay.
or your dextrose push.
All right. And then there was another one discussing the use of duonebs versus straight albuterol alone. When do you go to one over the other?
For me, it depends on their severity. Again, just mild expiratory wheezes, they're not in distress at all, I'd be happy to try an albuterol and see how they respond to that. But somebody who is in visible distress, working to breathe, to tachypnic, already got a bunch of albuterol at home, I'm going to go straight to the duoneb.
Okay. And there was another question here. Shouldn't any anaphylactic patient be transferred, not just hypotensive? They may need more monitoring and additional epinephrine.
So again, that will depend on several factors. Again, a patient early in shifts, with adequate staffing, comfort level of the provider and ancillary staff that's on, they can be monitored at least in my office, they can be monitored and we can observe there. That being said, on a day where, there's 2-hour wait to see patients, I don't have a nurse, I don't have the ability to stay on top of revitaling those patients, the patient poorly responded, anything like that, I could definitely transfer them. And again, if it's, we close at midnight, the patient comes at 11:45, I'm transferring him. So it's not an automatic. There's several factors to take into account.
And I think it's safe to say that your staff thanks you for that. So there was another one over in the chat. It's for asthma and croup. How do you administer the dexamethasone, oral or IM? Is there that much of a difference in terms of onset and effectiveness?
Generally speaking, I will do oral. IM is if I have a poorly cooperative patient who often vomit that right back at you, I will go IM for them. Also, if they're in severe distress and I don't want them aspirating it, I will go IM.
Absolutely. Okay. Well, I think that's all the time that we've got for questions. I'm going to switch over and just kind of give a little bit of a summary here and some additional points, and we're going to go through and do a quick demonstration of evidence-based urgent care. So one thing I do want to ask you all to consider is joining our Facebook group, and it's entitled EBM, which stands for Evidence-Based Medicine, Urgent Care Clinicians. And Valerie with EB Medicine is going to share the link to that Facebook group. And here we have ongoing discussions, foam med, pearls, tips and tricks and things like that. But we really want to grow this community and bring more people into it so that we can have discussions just like this on, a wide variety of urgent care topics. So for the last couple of minutes here, I just want to introduce this new resource exclusively for urgent care clinicians. I'm very excited to be involved with it, and it's called Evidence-Based Urgent Care. It was developed by EB Medicine with input from the Urgent Care Association and the College of Urgent Care Medicine. And as today's webinar is very PED specific, I want to point out that some of the past issues of evidence-based urgent care are very much relevant to our pediatric population. And there's a new and evolving KidBit section in the newer issues that are coming out. November's issue, just next month, is going to be on asthma, and we have a pediatric pneumonia issue coming out in early 2024. And as you can tell, we're very interested in getting more pediatric urgent care content out to you. And that feedback actually came directly from the Facebook group that I mentioned just a few minutes ago. If you have any questions during this demonstration of evidence-based urgent care, please put them in the Q&A and I will answer them. If you like what you see, click on the link on the screen or in the chat to subscribe. So I'm just going to share my screen and do a quick run through of, let's see here, options. Bear with me for 1 second. Let's see here. Val, here we go. Okay. Share something screen. All right. Okay. So if all of you can see my screen right here, what we have is an issue of evidence-based urgent care. And you can click on, it's all digital. You can click on the full issue. There's some other little tabs up here at the top. Each issue does come with 4 CME credits each month, so a total of 48 over the course of the year. If you look on the left side of the screen, you can just toggle on and off of this table of contents, and you can see all these things. I'm not going to read all these out to you, but it really does take a single topic each month, and it goes through etiology, pathophysiology, or differential diagnosis, what diagnostic studies, the treatment, special populations are included in a lot of the issues. We've also got disposition and transition of care. And I think that Dr. Rzonca did a fantastic job illustrating that struggle that we have in the urgent care setting. When you've got that patient and, what do you do? Does this patient need to go to the emergency department, or how can you safely and effectively take care of the patient in urgent care? So the disposition is also addressed quite deeply in each month's issue. Time and cost-effective strategies, again, the KidBits, special consideration in pediatric populations, and we've also got the conclusion of the case studies that were introduced at the beginning of each issue. Lastly, and this is something that really sets evidence-based urgent care apart, is that there's a lot of emphasis on coding, charting, all of the things that you have to put into your documentation so that you can get reimbursed for the work that you are doing. And then lastly, there are risk management pitfalls for each clinical scenario, and then there's a clinical pathway. So I'm just going to kind of scroll through this issue and give you a little insight into what it looks like. So we've got the case presentations, introduction with the demographics and the epidemiology that's associated with each one, your pathophysiology. There are a lot of tables that really are helpful for you to be able to look at. All the information is laid out quite nicely, differential diagnoses. A lot of what we read in the urgent care world is based on emergency medicine or family medicine. And EB Medicine has identified the fact that urgent care is its own animal. It's its own very unique patient population and clinical setting with some of the limitations due to lack of testing. We're not admitting patients into the hospital from urgent care, so we really have to practice in a unique environment. So all of this is really directed towards the urgent care setting. Diagnostic studies, again, fully understanding that we may not have all of the tests available to us in the urgent care setting as we do in the emergency department. Treatment, recommendations for different medications, and all of this can be used to improve your overall global knowledge, but it can also be used at the point of care as a reference. And at the very bottom, we talk about some of the risk management pitfalls, again, for each clinical entity. None of us like to have that discussion. Hey, remember that patient that you saw last week? Because we know where that's going. It's never good. So there's a lot of really good points and pearls on the medico-legal aspect of it. And then lastly, at the very bottom, we've got a clinical pathway for each clinical entity. So I hope that you find this helpful and interesting. And if you want to dig a little bit deeper, feel free to send us any questions. Again, join the Facebook group that we've got, and we can continue some of those discussions there. So that is that. One other thing that I would like to share is, let's see here. Yes. Okay. So as you can see here, share the tab. Okay. Can you see that right here? All right, so evidence-based urgent care. If you subscribe, what you get is you get access to each month's issue, and you also get access to all of the previous issues. To date, there are about 20 monthly issues that have been sent out covering a wide variety of topics. Some of them are, again, pediatric specific, the ones that I mentioned earlier that are coming out. Over the course of a year, you get 50 or close to 50 CME credits. It's also fully available online as well as the mobile app, which is fantastic. You can access all of the courses, the EKG course, the laceration course, and evidence-based urgent care directly through the app. If you subscribe now, then you also get a free EB Medicine t-shirt, and you can purchase to get 20% off using the promo code webinar2 if you go to ebmedicine.net/urgent-care.cme. We'll have that link over here in the chat if you're interested in learning more. So I think I'm going to stop sharing. All right. So just to close up here, we want to thank everybody for joining and hope that you enjoyed today's event that was sponsored by EB Medicine and the Urgent Care Association. We're offering this special treat for y'all staying to the end. Again, just what I mentioned, webinar 2. If you use that promo code webinar 2, you get the free EB Medicine t-shirt and 20% off evidence-based urgent care subscription. This is a limited time offer, so act fast, go ahead and join. And I'd like to thank everybody for joining today, and a very big special thanks to Dr. Merissa Rzonca for being our expert and providing us with a very timely, as we're heading into the respiratory season, a really, really good presentation that I think all of us can take something meaningful away from. Dr. Rzonca, we really appreciate your time putting all this together. For everyone who registered, you're going to receive an email with a link to the recording within the next week, and you can post additional comments and questions on on the EB Medicine private Facebook group. Thank you all so much for joining and being here with us today. Sorry for going over a little bit, but thanks for sticking around. Don't forget to take advantage of the 20% discount and the free gift, again, using the promo code webinar20. And to exit, all you have to do is close your browser. I hope that you all have a great day, and thanks for your time. Thanks for joining.